Hello, everyone, and welcome. I will give everyone just a second to transition from the waiting room over to our presentation with the wonderful Mariah. I hope that you all are enjoying the summit so far. I encourage you to use our chat, share your questions, share your comments, your feedback. We welcome it all. Again, my name is Jamie Singletary, and I am the Senior Director of Clinical Brand and Community for Within Health. And again, one of the many faces that you will see over the next couple of days as we navigate through the Within Summit. Going back over just a few housekeeping, if this is your first time joining us today, want to make sure that you are aware that this particular talk will be recorded and you will have access to review this recording in your CEGO dashboard. If you are here to obtain CE credit, you will need to be watching this presentation live in order to receive the 1.5 credits that is offered. If you go back to watch the presentation on video, you will not get credit for that. So just want to make sure that we are clear. I will also put some contact information for CEGO in the chat should you have any technical issues. If you have any questions regarding the summit logistics, I will also have my email address in there as well so that you can contact me. And without further ado, I'm going to read a little bit about my colleague and friend Mariah, and then we will get started with our presentation. Mariah is a registered nurse who has been working in the field of eating disorders for the past 4 years, and prior to that, spent several years working with medically complex children and adolescents in both inpatient and outpatient settings. She is a certified pediatric nurse and has been recognized on multiple occasions for demonstrating exceptional compassionate patient care. She is passionate about the complex dynamics of navigating how underlying medical conditions and medical complications can impact eating disorder treatment and recovery. Mariah works tirelessly to help clients advocate for themselves with healthcare providers. In addition to caring for clients directly, Mariah also oversees a team of nurses at Within Health, ensuring the highest quality of care. Mariah, I'll turn it over.
Thank you, Jamie. Before I jump in, just to let everyone know, I'm in the midst of daycare illnesses, so I may need to pause at some point to cough or blow my nose, so I apologize, but just throwing that out there. But I just wanted, good afternoon, everybody. My name is Mariah Eichelberger, and I am a senior nurse lead at Within Health. And in this role, I care directly for clients and I work closely with their outpatient medical providers in providing medical management as they undergo treatment for their eating disorders at the PHP and IOP levels of care here at Within. I frequently find myself working with medically complex clients, including a handful of clients with a mast cell activation syndrome diagnosis, and even more with potential mast cell activation syndrome who do not have an official diagnosis at this time. My expertise on this topic comes from this direct experience working with my clients and their providers, as well as from extensive research on the topic and completion of a rigorous mast cell activation syndrome professional consultation group with Dr. Jennifer Gaudiani, eating disorder expert physician. Moving forward, I'm going to refer to mast cell activation syndrome simply as MCAS or just mast cell for the sake of everybody's time. Before we jump in today, I do want to preface this talk by acknowledging that mast cell is an emerging and very nuanced topic, and there is still a lot of research to be done and questions to be answered. It is thought to be a very common yet under-recognized chronic disorder. The first case reports of mast cell were only published about 15 years ago. And those that consider themselves experts in this field, myself included, are still learning more every single day. There are still many more questions than there are answers, which can be incredibly frustrating. This presentation will review the pathophysiology, diagnosis, and treatment of the disease, with a particular focus on considerations for the eating disorder population and the role that non-prescribing members of a client's treatment team can play to support the client when there is a suspected mast cell diagnosis. So the objectives today, I'm hoping that by the end of this presentation, everyone will be able to list at least 3 symptoms of a client's presentation that could indicate potential mast cell activation syndrome. That everyone can describe at least one recommended step to be taken in the presence of suspected mast cell. Explain 2 ways mast cell can serve as a barrier to eating disorder recovery work, and name at least 2 potential ways you can support a client with a suspected mast cell diagnosis. So unless you're a medical professional, you've probably never heard of mast cells. Mast cells are a type of white blood cell that play an important role in our immune system detecting and responding to foreign substances throughout the body. Mast cells are best known for releasing histamine and being a key player in serious allergic reactions, like someone having anaphylaxis from bee sting or peanuts, or an asthma attack triggered by something like smoke. These mast cells are present throughout the body, but they're more prevalent in environment-facing surfaces, including the GI tract, lungs, genitourinary system, skin, and along blood vessels and nerve endings. When these little cells are activated by a trigger, they have the capacity to stimulate over 1,000 mediators. Among those, histamine, heparin, and many inflammatory factors. And these are chemicals which mediate reactions throughout the body and serve to protect the body from harm. So when mast cells are well behaved, they only release these mediators in specific circumstances, such as anaphylaxis or locally due to a bug bite. A normal mast cell reaction is appreciated, such as a fire truck showing up to a house fire would be. However, mast cell activation syndrome happens when mast cells misbehave and aren't working properly. In individuals with mast cell, there's an inappropriate release of mast cell immune mediators into the body, leading to symptoms across multiple organ systems, which can range from mild to life-threatening. It is important to recognize that mast cell is not a problem with an overproliferation of mast cells, as seen in conditions that are more commonly recognized, like mastocytosis, but rather mast cell activation syndrome is an excess production of the histamines and mediators produced by an ordinary number of mast cells. I like to reference this picture. It's a very rudimentary drawing, but it kind of I'm a very visual person, and I love to kind of have this reference. This shows a mast cell at rest, which you can see is, kind of clean and tidy. And when a mast cell becomes activated, it degranulates, or I think of it almost as exploding. And tiny mast cell granules containing various mediators are released throughout the body, and these mediators cause these multisystemic effects, which we'll be talking about shortly. There is a large population of humans across the planet who have mast cells that are unstable. They release their contents when they're not supposed to. It's going to be astounding to you how many symptoms can emerge just because of a mast cell that releases its contents when it isn't supposed to. We are not exactly sure how this all comes about. We think there probably is an inheritable element. We think that the various things that we are exposed to in our world, such as chemicals and scents, probably coordinate with some genetic predisposition. And beyond that, usually each individual has to have one or more triggering episodes in their lives to bring this into being, including physical and psychological stressors. And these can be things like the increase in estrogen around puberty or perimenopause, as Chrissy was just speaking to, GI illness or a parasite while traveling, could be mold exposure, and eating disorders can also be one. Eating disorders are incredibly stressful on the body. Research estimates that up to 17% of the population has mast cell activation syndrome, and it shows a strong female predilection. Interestingly, some individuals with mast cell barely have any symptoms at all and never worsen, and others have ultra severe symptoms and end up in inexplicable anaphylactic shock in the hospital weekly, while the majority of people are going to fall somewhere in between. Each person's presentation, severity, triggers, and treatments are going to be unique. Doctors just in the last 15 years or so began realizing that inappropriate mast cell activation is likely one of the single issues underlying many patients with large lists of problems, of general themes of inflammation, allergic type issues, and a wide variety of dystrophisms, means abnormalities in growth and development in potentially any tissue of the body. It is estimated that there is an even higher prevalence of mast cell in the eating disorder population. More research is needed to quantify this prevalence. You may ask why. Why is there such a high prevalence in the eating disorder population? And this is not entirely known. However, there are different hypotheses, including worse gut function, which predisposes individuals to restrict food as the negative conditioning of eating begins to outweigh the positive experiences that most people experience with eating and makes the road to nutritional rehabilitation and recovery so much more painful and challenging. A large number of healthcare providers either haven't heard of mast cell activation syndrome or don't believe it exists, despite predictions that it affects such a large proportion of the population. There are a few reasons for this, including providers having a hard time believing something that is so hard to measure by a blood test, vital signs, or a scan. The very broad and non-specific symptoms that can arise as a result of mast cell, and it being something that providers didn't learn about in school or training. We will speak about these various challenges in the coming slides, and it is so important to be aware that this is currently a condition that is poorly recognized in the medical community. Okay. I would like to introduce a case which I am going to reference throughout the remainder of this presentation. Jane is a 40-year-old cisgender Caucasian woman with diagnoses of anxiety, depression, POTS, IBS, and OSFED, presenting with restriction, binging, and purging as her primary eating disorder behaviors. And this all started, her eating disorder started with food group restriction around age 13, as she was finding that eating and food in general just was making her feel sick. Jane was diagnosed with mast cell in 2022 after seeing a new PCP after decades of suffering from a long list of seemingly unrelated symptoms, which never showed any significant improvement with eating disorder treatment, nor traditional medical treatments, despite seeing numerous specialists, including allergists, gastroenterologists, dermatologists, rheumatologists, and internal medicine. Since Jane was a little girl, she's had stomach aches and experienced nausea after meals, which made it hard for her to eat. She's never had a quote unquote normal digestive system with chronic severe bloating, alternating constipation and diarrhea, and GERD. In addition, she feels like she's allergic to her period, which each month is accompanied by terrible cramps and mood changes. She has a history of getting random hives on her skin, and on a couple of occasions, she has had severe allergic reactions to unknown triggers, once requiring an ER visit as her throat began to close, which was really scary. Dermatologists and allergists had no idea what was causing these reactions, as her allergy tests always come back negative. Further, Jane experiences chronic pain, especially in her joints, as well as chronic fatigue. She constantly has a drippy nose and has noticed she feels severely ill after just a few sips of alcohol, including symptoms such as headache, flushing, nausea, and acute worsening of depression for several days after drinking. She also experiences significant jumps in her heart rate when she stands up and frequently notices dizziness. It can be hard at times for her to just take a shower or stand in the kitchen to cook a meal. She's been told repeatedly that recovery from her eating disorder will fix all these symptoms. It's all due to her eating disorder. However, she's fully rate restored in treatment many times and has found this not to be the case. While the symptoms felt real, there were times that Jane thought maybe she's just overly sensitive. It was not until she received the diagnosis of mast cell and started treatment that she noticed meaningful improvement in all of her symptoms and really started to make meaningful progress in her eating disorder recovery and in healing her relationship with food. We're going to talk more about Jane shortly as we go through the remainder of this presentation, but I wanted to give a brief intro. I could easily spend an hour just going one by one through potential symptoms that someone could present with. However, I'm not going to do that to you. What is important to remember is that mast cell symptoms can often occur across multiple organ systems, can come and go seemingly randomly, migrate, and vary dramatically in intensity and presentation. Frequently, symptoms flare in response to triggers, i.e., major physiological or psychological stressors, which we will discuss shortly. Any one of these symptoms could be related to a wide variety of causes, but a whole bouquet of them across organ systems is highly suggestive of mast cell. I only included a sampling of symptoms on this slide. Some common symptoms I would like to highlight include skin sensitivity, including flushing, itching, rash, redness, or hives, feeling feverish with or without an actual elevated temperature, extreme fatigue, pain, especially in the joints, abdomen, bones, or muscles, headache, drippy or stuffy nose, sinus congestion, throat clearing, difficulty breathing, coughing, eye irritation, swelling, especially of the feet, hands, abdomen, or face, worsening of rapid heart rate, lightheadedness, and fainting, blood pressure instability, easy bruising and other bleeding problems, painful lymph node swelling, excessive sweating, digestive distress, which frequently worsens after eating, including pain, nausea, bloating, and loose stools, surges in depression and/or suicidality, mouth sores, brain fog, nerve issues, bipolar 2-like mood disorders, unexplained changes in weight, and painful and heavy menstrual cycles. If too many mediators are released into the system all at once, someone can experience anaphylaxis. Every patient is going to present differently. Some may have only a few symptoms, while others are going to have and present with many, many symptoms across the spectrum. Symptoms of mast cell are confoundingly diverse due to the presence of mast cells in every vascularized tissue, and because mast cells produce and release more than 200 different mediators, each with a unique array of direct and indirect, local and remote, and acute and chronic effects. So, given this vast array of symptoms, these patients are often being treated separately by many different specialists who are puzzled at the patient's real but unmeasurable symptoms and their lack of response to typical care. Frequently, these patients have for years been passed back and forth between providers and been told, it's all in your head, or you're just sensitive. We will speak about this more shortly, but such conclusions from powerful and trusted clinicians can be truly devastating and can deeply undermine patients' sense of self or themselves, their trust in their bodies, and their ability to believe their own symptoms. As briefly mentioned while discussing symptoms, triggers are physiologic or psychological stressors which cause the activation of abnormal mast cells, thus leading to the release of immune mediators and, therefore, symptoms showing up. These are not the root causes, but rather the conditions that trigger mast cells to misbehave in someone who is genetically predisposed to mast cell activation syndrome, resulting in symptoms or worsening of symptoms. So some common classic triggers for mast cell include alcohol. And this is alcohol of any kind. We may frequently think of, ingesting alcohol, wine, beer, liquor, all of that. But it also includes alcohol in skin products, in makeup, in topical products, oral like mouthwash, something other than alcohol, than, liquor, but is still alcohol going into the system. We also think about another trigger is artificial dyes, and this can include FD&C red, yellow, and blue. And this includes common products you may think of, such as foods, as well as medications. A lot of medications contain dyes, supplements, drinks, and soaps. Going back to Jane, she actually recently realized, oh, so this is why I get flushed and have stomach ache when I eat M&Ms, but I can eat a chocolate bar just fine. Mold is another common trigger. Someone living with mold or, in an environment with mold is never going to get better. No matter what triggers are avoided or medications are taken, mold puts so much stress on the body. Extreme heat and sun exposure is another one. Most clients with mast cell find that they feel worse in the sun. Jane has found she feels much better during the cooler times of the year. Scented skin and home products can also be a common trigger, as well as stress. And this is we're talking about emotional and physical stress. So this can include anything from, final exam week, family conflict, or menstruation, to being sick, such as having COVID or the flu or a cold, like I do right now. It is important to note that clients with chronic PTSD and/or high anxiety may be particularly susceptible to mast cell flares as they're living in a chronic state of heightened stress. And speaking of that, eating disorder behaviors are incredibly stressful on the body. So, restriction of calories, binging, and purging are all going to be major triggers as they are so stressful to the body as well as to the psyche. And then we talk about specific foods. While this needs to be handled delicately for someone with an eating disorder, some individuals with mast cell can legitimately react to a broad variety of foods. Jane has found she's very sensitive to gluten products. When she consumes gluten, she frequently ends up with severe gastrointestinal distress and finds herself glued to the toilet for hours with severe diarrhea. I'm not talking about a little bellyache or some nausea. I'm talking about severe gastrointestinal distress. Everyone will have their own individual triggers that's going to vary depending on how active their mast cell is at the time. One of the huge challenges in mast cell is that triggers can change from week to week. So Jane, going back to Jane, she has found that something that makes her feel crummy the week of her period may be completely fine for her the week after. And she finds that during highly stressful times, her mast cell reacts to more triggers than during times she's well rested, nourished, hydrated, and feeling supported emotionally and just better regulated. For example, Jane actually has no problem eating M&Ms and can better tolerate gluten when her mast cell is well controlled and she's well rested, nourished, and hydrated. I want to share this is a mast cell activation syndrome mini screen, which was created by Dr. Jennifer Gaudiani and is used at the Gaudiani Clinic to determine if a patient who does not currently carry the diagnosis of mast cell activation syndrome should undergo further evaluation and proceed to fill out a more extensive questionnaire to help diagnose mast cell. It consists of 6 questions. Do you feel you have physical reactions to food, medication, scents, or body products? When you drink alcohol or use alcohol-based products like hand sanitizer, do you get flushed, itchy, have abdominal pain or distress, worsen mood, joint pain, or feel flu-like? Do you often get rashes, hives, or itchy skin? Do you feel unwell, swollen, rashy, itchy, or fatigued after spending time in the heat or the sun? Do you experience pain regularly, especially joint, digestive, head, or muscle pain? Do you feel chronically or frequently fatigued, unexpectedly fatigued? If a client answers yes to 3 or more of these questions, it would be considered a positive screening test, and further evaluation for mast cell activation syndrome would be warranted. Jane actually answered yes to all 6 of these questions. This screening, along with several other extremely useful tools, can be found, including an more in-depth questionnaire, can be found in the resources section of the Gaudiani Clinic website. I do want to highlight that this is not a validated tool for making a definitive clinical diagnosis. There's currently no standardized set of screening questions for mast cell. However, there is a validated tool created by physician Dr. Molderings in Germany that is used productively in academic studies and at times in clinical practice, called the Mast Cell Mediator Release Syndrome Questionnaire, or the MCMRS. This questionnaire is quite long. It consists of 57 questions. So it's not super practical to use on a daily basis when we're just kind of trying to screen for the potential. But work is being done on developing a validated, standardized screening tool and patient assessment tool that can be used in clinical settings, as it is recognized that this is very, very needed. So there are 2 schools of thoughts among diagnosticians who treat mast cell. First, we have consensus 1 criteria, which require patients to display specific, severe, and recurrent allergy or anaphylaxis symptoms, an elevated tryptase level on a serum sample within 4 hours of a mast cell flare, and symptom response to mediator suppressors or mast cell stabilizers. The consensus 1 approach is more aligned with the academic realm, and in my personal opinion, can be quite problematic due to the limited set of symptoms that may not capture everyone, and due to testing being widely inaccessible and prohibitively expensive, as well as a very high likelihood of false negative test results, as these labs are very, very difficult to properly draw and handle. Research has shown that the consensus 1 approach may miss 85% of people who actually have mast cell activation syndrome. On the other hand, the consensus 2 model offers an alternative diagnostic framework, which is more inclusive and recognizes the complexities of the disease. As you can probably tell, I prefer this model, and this model is endorsed by a much larger group of physicians across medical specialties. Patients meet consensus 2 criteria if they have a unique constellation of symptoms that could arise from pathologically increased mast cell activity in 5 or more organ systems, and their symptoms respond to any treatment targeted at mast cells or their mediators. It is, of course, important to rule out other diagnoses that may account for the full range of symptoms prior to landing at a mast cell diagnosis. This model does not ignore laboratory testing, and lab testing can and should be taken into consideration if able. However, the lack of positive lab testing would not exclude a client from starting treatment, and if they respond to treatment, it seems reasonable to assume there's some sort of mast cell issue that's being managed. The consensus 2 model, in essence, says that anyone with a reasonable number of symptoms can empirically be started on mast cell treatment, and if they feel better, we conclude they have a mast cell issue. It is important as providers to understand that most patients with mast cell dysfunction in primary care will have normal lab tests. I recommend specifically preparing patients for this set of expectations if testing is ordered. Patients with normal mast cell labs may still respond to mast cell targeted treatments. Understandably, there may be concern regarding the potential overdiagnosis by consensus 2 criteria. However, underdiagnosis by consensus 1 criteria seems to be a far larger concern, given the increasing appreciation of mast cells prevalence, and that most mast cell patients, regardless of illness duration prior to diagnosis, can eventually identify treatment yielding sustained improvement. Of course, it is important to rule out other potential diagnoses when evaluating a client for potential mast cell activation syndrome, and differential diagnoses should be thoroughly explored prior to landing on a diagnosis of mast cell. So a little about treatment. The goal with treatment of mast cell activation syndrome is reduction of symptoms and improved quality of life. MCAS is not curable, and it is important for providers to set realistic expectations for treatment with the clients. That said, significant improvement in symptoms and quality of life is possible. It can be helpful to think of the bucket analogy, which is used frequently in discussion around chronic illnesses. This analogy compares the body to a bucket. There's always going to be some water, i.e., the mast cell symptoms, in the bucket, i.e., the human body. Every trigger someone with mast cell encounters is going to be a drop of water falling into the bucket, raising the water level little by little. Once water begins sloshing out or overflowing is when the symptoms occur. The goal is to keep the water level down and keep it from overflowing, and avoiding triggers can play a huge role in doing this. As mentioned earlier, everyone is going to have their own individual triggers, and these are going to vary depending on how active their mast cell is at the time. And the first step to trigger avoidance is identifying the triggers for that individual. Some triggers are going to be easier to avoid than others. For Jane, she was able to reduce exposure to heat by planning indoor activities on hot days. And when she does need to go outside, she brings a misting fan with her to help keep her cool. She also realized that while it felt really good in the moment on her joint pain to spend time in her hot tub each night, she consistently broke out in hives and felt ill and dizzy afterwards, so she stopped using the hot tub. She had stopped drinking alcohol years ago since it always made her feel so ill, and continues to live a sober lifestyle, which is luckily a lot easier these days. Jane had her house inspected for mold and had mold remediation done. She switched to scent and dye-free skin products and laundry detergent. She also has done her best to remove artificial dyes from her life. She switched from drinking Gatorade to a dye-free alternative for an electrolyte supplement. I promise this is not sponsored, but LMNT is a great one that's also higher in sodium, which can do wonders for rehydration with this population. She also seeks out white-colored medications without dyes. And while this can at times be tricky, her local pharmacist has been incredibly helpful in the process. Sometimes this requires compounding pharmacies or her pharmacist reaching out to try to find find her medications without dyes. She continues to work with her eating disorder treatment team to work towards eating disorder recovery and ensure she is nourishing her body properly. She does her best to mitigate stress, but also recognizes that she cannot avoid stress altogether and has begun anticipating that she will feel worse when she's stressed out. Finally, when Jane was first diagnosed, she identified gluten to be a trigger, which caused severe symptoms that impacted her ability to function and to nourish herself. So she began utilizing gluten-free options. Now that Jane's mast cell is being treated and is better controlled, she has actually been able to incorporate gluten into her diet again, but knows that when she's in a flare, it may again become an issue. Clients will need to be patient and show themselves, their treatment teams, and loved ones grace as they start paying attention to what makes their mast cell flare and under what circumstances. Some clients can clearly tolerate one of these triggers just fine, in which case they should listen to their body. The goal here is always going to be least restrictive living. In addition to trigger avoidance, medications can be a helpful tool for stabilizing mast cells and for blocking and mitigating the effects of released mediators. Finding a medication regimen that works is going to be a process of trial and error to find what that particular client responds to. And this process can be so frustrating and so stressful. And it can get worse before it gets better. Treatment involves many possible options and depends on the patient response. For Jane, it took several months to find a medication regimen that worked and significantly improved her symptoms. Generally, clients will start with over-the-counter histamine blockers, which assist in blocking the effects of histamine, which is one of the primary mediators which is released by these misbehaving mast cells, and can trigger a cascade of inflammatory responses. These are going to include H1 blockers, which are non-sedating anti-allergy medications such as Allegra and Claritin, as well as H2 blockers, which are reflux medications such as Pepcid. Typically, mast cell dosing is higher than the standard dose, but clients can start with a standard dose and go from there. In addition to H1 and H2 blockers, adding in mast cell stabilizers such as quercetin or prescription cromolyn can be helpful for systemic symptom management, specifically for digestive symptoms and skin manifestations. Additional medications may be indicated as well, including additional mast cell stabilizers, low-dose naltrexone, montelukast, benzodiazepines, Xolair, and others. I'm not going to go into a lot of detail on pharmacological treatments as I recognize that my primary audience is not prescribers today. However, if you are curious to learn more on this topic, there's a growing bank of literature on it, and I'll have several resources listed at the end of the presentation that can be helpful to refer to. Let me just take a sip of water. I want to highlight that many of the treatments for mast cell activation syndrome are over the counter and have very low risk profiles. So non-medical providers who feel that this applies to their patients can urge their patients to bring it to their primary care provider. And if their primary care provider is resistant or they don't have a primary care provider and are working on getting a more comprehensive care, clients can be empowered to start educating themselves using reputable sources, of course, and consider if they want to try some initial treatments independently in the meantime. Further, it is important to know that medications may need to be adjusted during a flare, as clients may require higher doses, as well as additional medications to control symptoms when they're experiencing a mast cell flare-up. Co-occurring conditions. So clients often present with a myriad of complex coexisting diagnoses, and the interrelationship is unclear. However, there is speculation about whether dysregulated mast cell responses and the recurrence or chronic release of mediators may be a pathological mechanism underlying many of these conditions. MCAS seems prevalent and may underlie much chronic inflammatory disease. POTS and hypermobile EDS or Ehlers-Danlos syndrome are so commonly seen along with mast cell that they are actually referred to in combination as a triad, which suggests that there's some common mechanism and potential for significant overlap in these conditions and symptoms. Studies are currently underway to further assess the relationship between these three clinical entities. There is a hypothesis that many cases of POTS are likely fueled by uncontrolled mast cell, which suggests that chronic inflammatory mediators of the central nervous system cause activation in a way that may lead to POTS. It's actually thought that up to 40% of those with POTS have mast cell, and treating the mast cell is going to help with the management of the POTS. In addition to POTS and EDS, other conditions are also seen to commonly co-occur with mast cell, including small intestinal bacterial overgrowth, which you may have heard referred to as SIBO, superior mesenteric artery syndrome, irritable bowel syndrome, eosinophilic esophagitis, and median arcuate ligament syndrome. Not much is known regarding the relationship between these conditions. However, it is thought that if you can reduce inflammation and stressors across the board, an individual's co-occurring conditions and their mast cell will likely both improve. And this has definitely been the case for Jane, who has noticed significant improvement in her POTS and IBS symptoms since starting treatment for her mast cell. So going into eating disorders and mast cell, there are so many considerations to be taken into account when a client has an eating disorder and also a potential mast cell diagnosis. And it is so important to recognize the relationship between the eating disorder and the mast cell. Due to reactions to foods and unpleasant and scary symptoms, mast cell frequently results in negative conditioning to and very complicated relationships with food and feeding oneself, which, understandably, can contribute to the development and the continuation of an eating disorder. Food can become terrifying, so no wonder so many people with mast cell have eating disorders, especially ARFID, which can maybe misdiagnosed as anorexia. It is important to consider that for some patients, eating disorder symptoms may serve as coping mechanisms for their mast cell. In addition, the physiologic stress of malnutrition is enormous and can drive the mast cell activation syndrome. It becomes a vicious cycle. And therefore, the treatment of the eating disorder is so key for management of the mast cell activation syndrome, and the treatment of the mast cell is going to be essential for eating disorder recovery. It really goes hand in hand. It is important for clients' eating disorder recovery that their eating disorder providers take into account the complex nature of mast cell during treatment due to the many ways in which their underlying medical disorder has likely contributed to and maintained their eating disorder. We must recognize that these clients have likely experienced gaslighting by doctors when they couldn't find a cause for their physical symptoms, which may have led them to undermine their sense of self and start to distrust their own body, which in and of itself can fuel an eating disorder, as most of us have probably seen. We will speak shortly about how we as providers can help clients to regain a sense of trust in their bodies and to advocate for themselves in a healthy way. One final point to make here is that it is important to recognize that untreated mast cell can impact someone's weight, driving weight loss, or on the flip side, actually driving weight gain. It is common to see opposites in so many aspects of human biology in various mast cell patients, i.e., we might see weight gain in some and weight loss in others. It's all a matter of which particular mediators are being apparently expressed in which particular amounts, at which particular times, and over which particular durations by the abnormal mast cells in particular places in the patient's bodies. So there's so many factors at play. Sometimes we will see clients eating very little who are gaining weight, which can perplex providers and the patient, and may actually be due to mast cells containing mediators that stimulate adipose tissue growth. There's still a lot of unknown here in terms of the mechanisms at play, but regardless, potential impact on weight can obviously impact a client struggling with an eating disorder and their recovery. And it is important for us as eating disorder providers to be aware of this potential so that we can better support our clients who may be experiencing this. So let's talk a bit about nutritional considerations. Essentially, someone with mast cell may react to a huge number of foods when they are in a flare. When flared, mast cell can cause legitimate reactions to many foods. And this is not necessarily their, I'm going to put quotes around this, eating disorder talking. And it's not simply going to get better with eating disorder recovery. Although eating disorder recovery greatly reduces the stress on the body and helps mast cell reactivity overall. It can be extremely tricky for a dietitian to manage an eating disorder and mast cell together. However, it is possible, and it is so, so important for these clients. What I'm about to say may be controversial, and it's important to consider. We must believe our patients when they say that certain foods make them feel bad. Encourage patients to tune into their bodies, which is not always an easy task, and help them differentiate eating disorder fears from physical mast cell reactions. Where there are lots of times that a patient's eating disorder may impact food choices and get in the way of them nourishing their body adequately, there are also times that these are real symptoms that clients are feeling, and it may be necessary for them to avoid certain foods. There can be space for both the eating disorder and there being an underlying GI issue. Might it be the mast cell or some other condition? Treatment providers and programs need to be open to real food intolerances while also holding firm that caloric inadequacy is never okay. The goal, as I mentioned earlier, should always be least restrictive eating tolerated. Many mast cell blogs and non-eating disorder informed mast cell providers may recommend restrictive diets, including elimination, low histamine, or low FODMAP diets. However, it is important to note that this is not an evidence-based intervention and can have some very harmful consequences, especially on this population of people with eating disorders or at a higher risk of an eating disorder or that, predisposition to an eating disorder. Unfortunately, I frequently see clients who have subsided on chicken and rice or some similar limited diet for literally years because they were at one point advised to do some version of an elimination diet, but they never received any guidance on what this might mean for their overall health or direction on how to reintroduce foods in a safe, effective, and tolerable way. I also think it's important to note that there is truly no such thing as a low histamine diet, as all foods can trigger histamines, and trying to eliminate all foods that may trigger a histamine reaction would mean living on so few foods, it would most definitely result in malnutrition and nutrient deficiencies. While restrictive diets may truly feel good to patients in the short term, they are not helping them in the long term, as the malnourishment is going to increase stress and reactivity. As clients begin nutritional rehabilitation for their eating disorder, they will need to start with focusing on the foods that can be consistently tolerated without mast cell reactivity. And then they can work on increasing intake of those foods until they are consuming enough to meet their daily needs. As their mast cell settles, they can then work on tolerating a broader array of foods. A tip I have found helpful is that freshly cooked food from fresh sources is typically more tolerable than leftovers. And many mast cell patients find it helpful to freeze fresh foods and thaw, cook, and then eat them same day. And this approach allows for a broader variety of food options while reducing the histamine risk. Also, in extreme cases, and I want to really say this is in very limited extreme cases, elemental shakes that are neutral for the gut may be needed to be incorporated early on in the process to help clients meet their energy needs until more foods can be tolerated. You may ask, what is the best way to tease apart an eating disorder from mast cell? And how do I evaluate and navigate these potential food intolerances? And that's a great question. And there is no one answer. Every individual is going to be different, and that's part of what makes this so sticky. However, I have some general tips and strategies I've used in my practice and have learned with working with some wonderful mast cell and eating disorder informed dietitians, therapists, and medical providers. And those include asking questions about what foods seem to make a client's body feel unwell. What happens when they ingest a certain food? Is it followed by an allergic like reaction or intense physical symptoms, such as Jane's intense diarrhea? Or are symptoms more mild and potentially anxiety related, such as mild cramping or nausea? It's also important to explore how triggering temporarily cutting out a trigger food will be for a client. And it's always going to be a risk benefit analysis when making those determinations. Another tip, encouraging patients with themselves and with their providers as they work to identify potential food intolerances, because this is not going to happen overnight. And it can be so powerful to have straightforward and honest conversations with clients about what is a true intolerance versus a fear food. It's important to approach clients with curiosity instead of suspicion, as suspicion is shaming and unhelpful, and really recognize that, clients know their bodies best. Also, for clients with identified food intolerances, exploring and asking them how can they still meet their nutritional needs, challenge their eating disorder, increase variety, and incorporate yummy foods. When I was working with Jane, gluten was a trigger. So we worked on expanding variety in her diet and challenging food rules by having her go to a local gluten-free bakery and purchase baked goods there, as well as exploring other yummy gluten-free foods. So there's ways that we can incorporate flexibility so that they can still have exposures and still have fun with food and explore variety. I also recommend working closely with the client's medical providers and the rest of the team to determine appropriate times when mast cell is well controlled to safely challenge foods which may have previously warranted a reaction. There is likely to be a lot of anxiety and fear about reintroducing a food which may have previously caused a reaction. So it can be helpful to provide space for processing before and after these exposures and challenging these foods. Also, if a client does experience a mast cell reaction when trying to reintroduce a food, I worked with a wonderful dietitian who would have clients set the food aside and suggest that they log it in a reactivity document and come back to it later when they're ready, after the mast cell is better regulated, and assuming it wasn't a super scary reaction, an anaphylactic reaction that landed them in the hospital, for example. When they are ready, they can retry it in a much smaller portion and on a rotational basis, such as every few days, without increasing the portion. And often the reactivity will go down with repeat exposure. I really try to lean in to their comfort level and honor their desired direction. I think trying to force a client to add a new food when they're not ready can really reinforce their aversion to the food and also reinforce those neural pathways that make food feel continually unsafe. Finally, I was recently introduced to the idea of approaching food the way we do medical care, with informed consent. And I found this concept very powerful. Informed food consent might look something like providing the most up-to-date research, providing validation, giving your recommendations, and then letting the patient decide what to do from there. What I have seen is this often allows the client to feel safe enough to start to work through undoing some of what the elimination diet was there to try to do, i.e., to protect them. And they can start to learn how to protect themselves differently with medications, with nervous system regulation tools, with incorporating a variety of foods and, being in a better nutritional state, etc. There is plenty that non-medical providers can do to support clients who may be dealing with mast cell activation syndrome or a potential mast cell diagnosis. First, MCAS can be recognized by any provider. While we obviously want to be mindful of scope of practice and a therapist or a dietitian is not going to give a client a mast cell diagnosis, if a therapist, dietitian, nurse, or any other member of a client's treatment team starts to suspect MCAS, they can and should encourage the client to start educating themselves and to discuss with their medical providers. Of course, when encouraging clients to begin educating themselves, we need to be mindful of the dangers of Dr. Google and the plethora of orthorexic and non-credible information that's out there on MCAS. And I would advise steering clients in a direction of reputable sources, which can include Dr. Gaudiani's 4-part blog on mast cell and eating disorders, as well as other resources that are listed in the references section of this presentation, which we'll get to shortly. These resources can serve as helpful references for medical providers, as well who may not be very familiar with MCAS. In addition, as we have discussed, MCAS adds another layer of challenge when supporting someone with an eating disorder. And it can be extremely powerful for clients to receive validation around these challenges and around the symptoms they are experiencing and have someone to sit with them through the distress. As mentioned earlier, those with eating disorders and mast cell may have a tendency to doubt their own lived experience and symptoms due to prior gaslighting. Taking clients at their word, listening to their lived experience, and letting them make decisions regarding their care is so important in repairing trauma pathways and in reestablishing trust with their own body. And in doing this, we can also empower clients to better advocate for themselves. Furthermore, it can be really challenging to find medical providers who are well versed in mast cell activation syndrome, let alone providers who are also eating disorder informed and can take into account the complexities of managing a chronic illness like mast cell while a person is also struggling with an eating disorder. Medical providers may be quick to recommend restrictive or elimination diets, which, as we've discussed, can be extremely dangerous for someone with an eating disorder. Eating disorder clinicians can assist by collaborating with their clients' medical providers, providing education to the medical providers on a client's eating disorder, helping discussing considerations for their care, and also advocating for least restrictive living possible. I also think when needed, it can also be very helpful to support and assist my clients in finding supportive, mast cell knowledgeable medical providers who are open to collaborating with the client's team and taking into account their eating disorder, which can be very challenging to find. I frequently remind clients that it may be hard to find a medical provider who is a good fit for them, and it is so important for them, and they are so deserving of that care. That's a soapbox that I will stay on all day. They're so deserving of that care. And sometimes it is a process of trial and error and trying different providers until you find the right one. Finally, clinicians can help support clients in coping with chronic illness and separating this from their eating disorders, so to improve their relationship with their body. They will likely need frequent reminders throughout this process that eating is not the problem, and we can support clients in living in self-knowledge, grace, compassion, and gentleness. There is so much more research to be done on this incredibly important and nuanced condition to help further understanding and recognition in the medical and psychiatric communities and to help countless humans who may be suffering. These conversations around mast cell are so important for increasing awareness and bringing more resources to research on this topic. And I encourage you all to support further research and to keep having these conversations. I now want to open it up for questions. I know I think Jamie's going to pop back on, and so I'll pause briefly.
Hi. Can you hear me okay?
Yep.
Perfect. Great job, Mariah. First of all, I just want to go back through the chat. I don't know if you were able to see, but you were getting a lot of love and compliments in the chat. They love the visuals of the slide. And Lindsay had a question, I believe, just wanting to know what about endometriosis and maybe some correlation between MCAS and endometriosis. I hope that's right, Lindsay. If not, will you please pop in the chat and speak further? But do you have any information on that, Mariah?
Yeah, so I definitely I don't consider myself an expert on endometriosis. However, I can say without a doubt that endometriosis is going to be a huge stressor on the body. So there can be a connection. I would say that somebody with endometriosis, it can definitely trigger mast cell activation. There's also I believe I'm trying to remember. I was just reading about this, but estrogen cells have a lot of mast cell receptors on them. So that's why when somebody is on their period, like around the menstrual cycle, you may notice a really big influx in symptoms for a client. So with endometriosis, I would imagine that would also come into play. And so if somebody is experiencing a flare up of their endometriosis, that could in turn flare up the mast cell and vice versa. Like I think it could very much be a vicious cycle and an interplay there.
Nicole had a comment. She says, I would love to see research on whether there is a connection between PMDD and MCAS.
Mm-hmm. I've definitely seen quite a few things kind of suspect like talking about there being a connection between PMDD and MCAS. As we talked about, as I was just talking about estrogen, estrogen has a lot of these mast cell receptors on it, so is highly impacted by these mediators that can be that get distributed when a mast cell is activated. And there is evidence that, like, we see clients who around their period have significant mood changes as well as increase in suicidality. So, very in line with PMDD.
Mhm.
And so I'm not sure. I'm going to have to look and see if I can find specific research. Unfortunately, there's just a lack of specific research when it comes to this topic. However, I have seen several places where, there is kind of where does cite the potential link between PMDD and mast cell. And I can actually, let me go to my next slide here while we're talking through this because it goes through some of the references, and these would all be great places to look to just get some more information on the topic. But there definitely is a connection.
Anna had a comment. She says, this is incredible information. Thank you, Mariah. Learning a great deal. This has been an absolute blind spot, fascinating and hopeful for many people I know. Thank you for paving the way to an entirely new, parentheses, for me, an extremely important avenue of knowledge.
Thank you.
See. Claire has a question. She says, have you seen any intersection between GLP-1 use and the onset of MCAS? I have heard about this happening in a few cases and was not sure if it's a broader phenomenon.
Yeah, I really don't know. And I am so interested in learning more about that. That with the explosion in the use of GLP-1s now, I'm sure that there's going to be a lot more kind of data and information coming out on that topic. So I guess my answer is I don't know. And I am very, very curious as well to learn more about that. That said, I actually did read something, and this was not specifically to eating disorders, but I have seen some anecdotal evidence of the use of GLP-1s in treatment of mast cell, not specifically to treat the mast cell, but that there are some providers who are kind of I want to use the word experimenting. It might not be the right word, but there is some conversation around like how those GLP-1s could impact both, I think like you said, onset of mast cell activation syndrome and like, bringing it on, but then also for someone who has mast cell. And I think there are some people who think that it can be helpful. And I really don't know a lot about it.
This is from Alyssa. Apart from dyes and alcohol, are there foods that are more common triggers to look at?
Hmm. Yeah. So, aside from dyes and alcohols, it is going to be really specific to the client. I will say, like we were talking about in the case study with Jane, gluten is one that I have seen more commonly. So gluten is a common one. Um, it is going to be very dependent on the individual. I would say, like I said, we don't recommend, or it's not evidence-based to recommend a low histamine diet. However, foods that are known to be especially high in histamines do tend to be more common triggers foods for clients. Um, and so kind of looking at those foods that tend to have a higher histamine content, um, are foods that we'll see more commonly. I know I also mentioned leftovers. So like food
Mhm.
that's been sitting for a couple days tend to have a higher histamine content as well, and can be more triggering. So I know I mentioned a little bit earlier that a lot of clients find that it's helpful to eat fresher foods, or because obviously no one has not, most people, I won't say no one, most people don't have time to cook fresh food for their family every single day. A great tip is to do kind of some meal prepping where you prep foods and freeze it that same day. Don't let it sit in the fridge for a couple days to see if you're going to eat it, and then freeze it when it's, when you haven't eaten it by, in a couple days. And then, if you freeze it, then when you defrost it, eat it that same day as it being defrosted. That has been a tip that I have had several clients find really, really helpful for decreasing reactivity. But going back to like just the foods in general, it is going to be very dependent on the individual. So it is going to be a bit of trial and error, and it may also change over time. As I mentioned, when someone's mast cell is flared up, they may react to a wider variety of foods. Um, and so unlike a food allergy, it's so crazy and it's so hard because the reaction, it can change what you react to. And something that you are fine with one day, you might not be fine with the next day.
This question is coming from Raquel. It's really helpful that so many of the meds are over the counter. At the same time, for many very low income clients, buying those out of pocket to see if they help can be a prohibitive expense. Have you seen clients able to trial those medication using insurance coverage?
That's a great question. And I
Mhm.
can't speak directly to the insurance coverage piece of it, but I have seen providers prescribe some of these medications that are available over the counter. And I am hopeful that, with the provider prescribing that they're getting insurance coverage of it, or at least, it's cheaper than it would be if they were just buying it over the counter at the pharmacy. I think it's probably going to depend on the insurance. Um, so I can't fully answer that, but I have seen providers prescribe medications that are commonly, available, like these H1, H2 blockers. Like I've seen those prescribed, so that they can hopefully receive some assistance with the cost.
This comment is coming from Kendra. She says, "Thank you for this important and helpful information. I look forward to learning more about the connection between eating disorders and MCAS." Our very own Emma. Hi, Emma. She says, "Also, many of the symptoms of endometriosis mimic those of mast cell." So
For
that goes
sure.
back to Lindsay's comment.
Yes, that is a great point.
Another question, any information on this with rumination syndrome?
So I don't have specific data, on comparing it to rumination syndrome. However, um, I think kind of similar to what was just said about with endometriosis, like the symptoms can mimic each other. Rumination syndrome, for those who aren't aware, can cause like frequent vomiting or like spitting up of food. And it can be, and obviously an eating disorder behavior where they then like swallow it again or rechew it. But this could also, I think it's so hard because those symptoms can mimic symptoms of mast cell, because like GERD, nausea, vomiting, all of those things can be so tied in. So it's definitely possible that there could be a combination. I also just have to think that, like, when you think about somebody who's been struggling with like these chronic GI symptoms for so long, that, these, it can kind of become a these behaviors could develop, as a result of these chronic symptoms that they're experiencing.
Looks like Anna was commenting food drinks that are considered high histamine at Elisa can be triggers, but not for everyone. Thank you all so much for commenting in the chat and supporting one another's questions and comments. Cheryl just wanted to say this has been great. This has been a great presentation, Mariah. Thank you so much. Heather says this is so helpful. Nicole also says, "Thank you for the great info. I look forward to learning more about MCAS and the references." We do have another question. How does Within Health support clients that can have co-occurring MCAS and eating disorders? What do we
Yeah.
do?
Yeah, so I think at Within, one of the unique aspects of Within is we are able to support clients with really complex medical pictures. We frequently get, clients with a, a lot going on medically, for lack of a better word, and acute eating disorders. And I think one of the unique aspects of Within is our nursing team, not to toot our own horn, but like we work really closely with our clients' outpatient medical providers to coordinate care. And so we will do a lot of collaboration with the outpatient team to ensure that we are meeting their needs as best as possible and kind of taking into consideration all of the various pieces that go into that client's overall picture. So in addition to that close collaboration, we're also trying to go back and tease out, what's the eating disorder versus what's mast cell, when it comes to food intolerances, which is tricky. I will say the dietary team here at Within, does a great job on focusing on foods that clients can tolerate while slowly challenging them to expand what the variety around that. And I will say that, I have had clients here where, where there are intolerances, where there is a food, that they just can't tolerate. And, I think we, as a treatment center and, do a pretty good job of acknowledging and accepting when that's the case, while also still trying to tease out, are there what's the eating disorder versus what's the mast cell. But we do, we do have to kind of respect and acknowledge that there are going to be situations where there are going to be certain foods that there are intolerances to. So I think, in terms of Within supporting the, that nutritional considerations that I was just speaking to, as well as that really, really close collaboration with their outpatient medical team, as well as one other thing that I think can be really helpful for our clients that I try to do, at least with my clients when I suspect potential mast cell or they're having a hard time, is helping them navigate the medical system a little bit better. Unfortunately, I think navigating the medical system can be so challenging. I say even for myself, I'm a nurse and I still find it challenging at times to navigate our medical system. So helping them learn how to best advocate for themselves with their medical providers, as well as helping them maybe they need to find a new provider or learn how to or again advocate with the current provider, find a provider who has more of a specialty in mast cell, or maybe who has more knowledge in eating disorders. I think it's trying might be looking for a unicorn to find a mast cell, like a eating disorder informed mast cell informed provider. I think Dr. Gaudiani is the only one that comes to mind. However, I think finding a provider who is knowledgeable in mast cell and is willing to collaborate and is willing to talk with the treatment team and is open to other points of view and to learning can be so huge and so helpful. So I think that's another piece where I try to really help my clients.
Very nice. Karen, thank you for sharing this. Karen says, as one that has recovered from an eating disorder and has recently been diagnosed with MCAS, thank you for speaking on this topic. It can be very tricky to navigate.
It is extremely tricky.
And Catherine says, fantastic presentation. I love how much time and energy you dedicated to learning this, Mariah, and teaching our team and beyond on how to support these clients. So lots of love and support in the chats. We do have another question. You touched on it a little bit, but it says, how would one go about finding a provider who's well-versed in MCAS? And in addition to that point, where can one find more information on MCAS?
Yeah. Yeah, and I was actually leading up to this presentation because I've done this presentation before, and I was like, I wonder if since I've done it the last time, if there might be a more comprehensive database or somewhere that exists now that we can search for, a mast cell informed provider. Unfortunately, I did not have any luck finding that. However, what I have found to be the best way to find providers is, you can use Google to an extent, like to find providers in the area, but I find using networking to be the best way to find providers. So if you're part of any like eating disorder provider Facebook groups, you can put out feelers there of, hey, has anyone had a client who has an experience, who's has a this diagnosis and has had good luck with, has found a provider who's been helpful, in this area, or who provides telehealth to this area. I would also say I am part of a big listserv. It's called the Mastermind listserv. And I can Mast Cell Mastermind. Sorry, it's a little pun. But if anybody is ever having a hard time, feel free. I can put my Jamie, if you could put my email address in the chat, or I can
Sure.
put my email address in the chat. Um, I'm happy to kind of put out feelers as well to try to find here, I'm sorry, I'm putting my email address in the chat real quick. That yeah, I can try to put feelers out. There are also Facebook groups that are specific for mast cell providers, so those are also great resources. So those are some other ones as well.
Yes, and Karen also mentioned that there is a Facebook group. Also, I see that there is another question. I believe it's saying what psychiatric disorders are co-occurring with MCAS that you see.
Oh yeah, there's several. Sorry, I'm having one other thought related to the last
Yeah,
question
go
around
back, go
providers, and
back.
the other thing is to look at providers that specialize in EDS and POTS. Because a
Mhm.
lot of times with those being so frequently co-occurring, there is a lot of overlap in the knowledge there. Um, in terms of co-occurring psychiatric disorders, I think everything, anything and everything. I've seen links with OCD. I've seen anxiety, depression. Um, what was the personality disorder? So it's really anything you can imagine. And I've seen pretty much everything been referenced as can be co-occurring. The was why look sorry, my brain isn't working, but why that is, it's not really entirely known, but there is thought of neuroinflammation potentially playing a role here, and how neuroinflammation can contribute to some of these disorders, um, and that really contributing to a lot of the neurological and psychiatric symptoms. But there's such a broad range of symptoms. And then we also think about kind of what came first, the chicken or the egg, as well as
Mhm.
like when you've been dealing with chronic illness for so long and been gaslit potentially by providers, and been unable to find solutions to these symptoms, that can also in itself, drive mental health issues. So I've seen clients, obviously depression, can be, cause depression. OCD, maybe they find that like, oh, well, if I only eat these two foods, I think I
Mhm.
feel a bit better. And then that can just spiral into a lot of rigidity, and into more, more OCD thoughts. So there's a lot at play there. And there
I have
needs to
a
be more research as well. I'm just going to always put that in there.
And then there's a comment from Elise. Hi, Elise. It says, thank you for this comprehensive information about MCAS. I have a client who has come back after 20 years and has now been diagnosed with MCAS. This presentation was so helpful. Thank you.
It's wonderful to hear.
That's great. And then we have another question. You have so many questions, Mariah. This one
Okay.
says, when would someone begin to explore a diagnosis of MCAS, or if they think this is what they may have, when would you recommend that someone start looking into that?
Yeah. And I would say I'm generally so I think as I mentioned earlier, I'm starting to think about mast cell when I'm seeing a wide array of symptoms across body systems.
Mhm.
I think when other diagnoses have been ruled out, I think we always need to be mindful of like, is there something else that could explain what we're seeing, especially the whole array of symptoms that we're seeing? I'm also going to really start thinking about mast cell when traditional treatments are not working. So my clients were like, I've seen the GI, I've seen the allergist, I've seen the rheumatologist, I've done all of the things and nothing is helping. That is another thing that kind of starts to trigger in my brain, like, okay, maybe we're dealing with some mast cell something going on here. As well as my clients in chronic eating disorder treatment, clients who have really been dealing with their eating disorder for a long time without improvement. Like in the case of Jane, maybe they've weight restored more than once and their symptoms have remained. And it feels like their symptoms are a big barrier to the recovery. When I see seems like what it's holding them back in recovery. And no matter how many specialists they seen or all of the things that they've tried, it's not getting better. That's a lot of times when I start to go, there's something more going on here. Like, what could explain the bigger picture of like all that we're seeing? And I might start to go down the road of like, I wonder about mast cell, and start to maybe ask some of those probing questions that we explored when we were looking at that screening tool, kind of starting
Mhm.
to my wheels will start turning a little bit there.
Thank you. I believe that is all of our questions and comments. I just want to echo what's already been said in the chat, Mariah. It's always a pleasure to share this space and stage with you. This presentation was absolutely phenomenal, filled with such insight and a lot of good takeaways that people will be able to use from here on out. We will have our final CE presentation of the day here at 3:30. We will be joined by our Chief Clinical Officer, Rebecca Brum, who is going to tap into grief. So again, thank you all so much. Take a little bit of a break, and we will see you back again at 3:30. Thank you. Bye.